This is basically a case that they showed to illustrate some of the points they wanted to illustrate. And this is a 16-year-old young man who had seizures that consisted of what he described as muffled and confusing noise in his left ear, followed by leftward axial gyration and the clinging of the hand, the movements, and then chewing movements, loss of consciousness, and hypotonia. So by simply looking at this semiology, they wanted to sample areas in the brain, anatomofunctional areas of the brain that may be corresponding to these semiological features that were described as part of the seizure. So in order to cover the first part of the seizure, which is the aura of muffled and confusing noise, they chose to cover the Heschel gyrus and the superior temporal gyrus. These are two of the main areas that either are responsible of primary hearing areas or secondary post-processing areas of the brain. The second part of it here is to put electrodes in the middle temporal gyrus in order to define the inferior extent of the epileptogenic zone. And this is something they come back to every time they talk about the pre-implantation planning, which is the placement of electrodes around the area of the hypothesis. So the hypothesis, it is here Heschel gyrus and superior temporal gyrus. The electrodes to be placed are got to be anterior, ventral, posterior, and dorsal to the hypothesis. Next here is to have electrodes in the amygdala and hippocampal formation. And this is to study that the possibility of involvement because of the automotor movements here, and possibly their inclusion in the resection if the area of so-called organization, which is the very first formation of the ictal pattern, does involve the hippocampus and amygdala. And then here there is an electrode in the parietal opercular region, and here basically to cover the part of the motor areas of the brain, but at the same time to constitute the dorsal coverage of the main area of the seizure onset hypothesis. Other electrode here back, it will be in the inferior parietal lobule and the precuneus, and this is to cover two things: the dorsal posterior part of the epileptogenic zone, and then the gyratory movements here that in which the precuneus could be playing a role. And last but not least here, put in an electrode in the temporoparietal junction here. Again, this would be covering the posterior extent of the region, region suspected epileptogenic zone. So effectively here, in many cases, if there is a very clear analysis of the seizure semiology, the bulk of the anatomy to be covered, or the anatomy and function to be covered, could be created simply by this type of analysis. Now, the pre-implantation planning here, there are some three major concepts here they talk about. And the first concept is about the order and sequence of semiological signs. This is very important, and like our colleague and mentor Patrick Chauvel here, he published back in 2001, he talked about it, and he described that Bunko regarded this concept of sequence and order of semiological elements as crucial, and found analogies with the syntactic organization of words in a meaningful sentence. So any language has certain rules for organizing the words in particular sequence. And in any language that you speak it, there should be certain type of order to this sequence in order to make sense of the words in the context of each other. And this is the same for a particular semiology that has to be confirmed by the anatomy through the recording of the electrical activities and correlating this with the clinical manifestation during the recorded seizures. So that is the first concept here of real importance. The second, uh, probably even more important here, is the concept of the silent ictal onset region. And this is something that is distinctly different than the bulk of how we used to think that you hear in at Cleveland Clinic, which is basically looking at the aura or the first clinical sign as the potential seizure onset area. But here they expanded this, saying that, of course, the aura and or the first clinical sign could be the seizure onset in the seizure onset zone, but we have to consider a spread to that region coming from what we may call silent areas, mainly association areas of the brain, such as the parietal lobe and the prefrontal premotor cortex. So now this here, the SEEG will give the idea here, the implantation of the SEEG based on semiology, and then extended the semiology to potential silent areas that could be connected to the semiological areas in the brain, will come up with a three-dimensional sampling of the network involved in the seizure. The third concept is basically to do the anatomical correlation with the EEG and the semiology. Again, as I mentioned in the beginning, the SEEG, actually the principal SEEG, is to define the anatomy of the seizure onset zone, and consequent to that, the seizure, the areas that are involved in seizure semiology, with the help of the EEG, looking at ictal patterns, and semiology, correlating the involvement of some areas with the expression or semiological expression of various elements of the seizure. So let me here share with you a case to illustrate some of the points I made here, and then to take it to next level, which is how to use this information to analyze it in order to come up with a final hypothesis about where these seizures may be coming from. This is a 35-year-old right-handed male whose seizures started relatively late at the age of 20, and seizures were, as reported by him and his family, described no aura, but the seizures were described as sudden behavioral arrest, followed by looking to the left in a non-tonic manner, then right face pulling and unresponsiveness. And the order here could be little bit different, could be sometimes the right face pulling comes first, then the mild left non-tonic head movement, and then or they could come both together. So here I'm showing you some still images taken from various stages of seizures that we captured. These are summary of 4 seizures that we recorded on these patients. And then you can see in the first and the third seizure, what we have a, in the beginning, a right face tonic, just a small thing. You see deviation of the face, pulling a little bit to the right side here, followed by eye and head turning, as you see in the third phase of the seizure. Little bit mild right face pulling, and followed by left head non-tonic deviation, and that with the eyes as well. The second type of seizures were during which the patient has both eyes and head turning at the same time. You can see it here. Not much of the face here pulling on the right side, but certainly you can see the eyes maybe first, followed by the head, all of them, both of them to the right, to the left side. And the third type of seizure, actually, where there was right face tonic and both eyes and head turning to the left almost at the same time. So you can see here, looking at the semiology, it is almost the same, but the sequence may be changing a little bit here, which could be concerning. But if we think about one of the major concepts or principles of SEEG, saying that the seizure onset zone may be coming from a uh, silent region of the brain, here we could start to invoke areas in the brain that are potentially in association cortex. So, but if we're going to analyze the seizure face value, we can say that in the beginning, right face tonic followed by eyes and head turning to the left, there is an involvement of the frontal opercular area or the ventral area of the precentral gyrus, and then the moving of the eyes to one side. You may invoke the superior longitudinal fasciculus and the two areas connecting the intraparietal sulcus with the frontal eye field. Now, eyes and head turning to first, basically here we're invoking mainly the eye motor area with its connection to the superior longitudinal fasciculus to the intraparietal sulcus. Now, right face tonic and both eyes and head turning left, basically here you can conceive as all three areas activated almost at once. And therefore, in these situations, although seizures look a little bit different from one to another, by simply doing this exercise, we are able to at least come up with hypotheses involving the intraparietal sulcus, activating the superior longitudinal fasciculus 1 and SLF3 to connect these three areas. Two of them are mainly active from a semiology standpoint. Now, what about EEG? EEG here can be helpful in some situation. The EEG shows, in this case, ictal onset, this faster activity in the left parietal region, and that is evolving in the same area before it does take on most of the left hemisphere with quite a bit of artifact, maybe some involvement in the right side toward the end of the seizure. Now, going back here, if we're gonna do this exercise, which is extremely important in the process of doing a thorough assessment before an implantation of electrodes, the electroclinical correlation, the electricity is pointing to the left parietal region. The clinical manifestations are mainly in the frontal region, in particular, two ends of the superior longitudinal fasciculus, SLF1 and SLF3. And the third one is potential silent area that could be coming from this here or could be other areas such as this purple region here in the basal temporo-occipital region that will be getting us to connected with direct connection going to the intraparietal sulcus and therefore could go more anterior. Now, there are other hypotheses that were not supported by the EEG, which could be the prefrontal region, could be to some extent the temporal polar region and amygdala, which we invoke in most cases, in particular these cases where the EEG is not very clear, and of course the MRI showing no clear lesions. So based on that, the plan here for SEEG implantation involved the left parietal region, involved the frontal eye field and frontal opercular region, and then of course to map the posterior extent of that activity here, and the basal temporo-occipital region, anterior extent and dorsal extent. You can see here, this is how the patient was implanted with the SEEG. Now, how can we interpret these results here? It's not always straightforward. We're going to go step by step and then talk a little bit about the findings. I'm going to focus on the ictal findings because interictal we've seen activities in the basal temporo-occipital region, in the parietal region, and in the frontal region, either as synchronized activity or fragments of this, either frontal, parietal, or temporo-occipital. Now we do have two types of seizures. One type we call them the silent seizures or no clinical sign seizures. And in these seizures, as you see here, there is some type of mild preparation, but mainly very this fast activity that is low amplitude for short duration, almost like 3 or 4 seconds, that is the outside that area of V, the posterior temporal occipital region, LF, is involving very at a much lower amplitude part of the P electrode, which is in the intraparietal sulcus. No involvement, and very small exception here, M prime, very tiny fast activity here for a split second, but without any evolution either in M, Q, or S. So these are the no clinical signs. Now the patient here, and if we want to map this no clinical sign, is mapped to the V, L, and F with potential involvement of the P electrode. Now he had clinical seizures similar to what I showed you earlier, and some of them were secondarily generalized. And then I'm going to show you the examples of each one of these seizures here, where more or less it's the same. It is this fast activity that we've seen in the V, L, and F electrode in the on the no clinical sign recording, but here they're involving both the parietal lobe, lateral parietal, and then here they are involving the M electrode, the eye field, and they're involving the frontal opercular region as well. So here you can see in simply this recording, this page, the map of the seizure going from a silent area to an association area to a symptomatically involved area in the frontal lobe. This is another seizure. The difference here we're seeing this what we call these pre-ictal preparation of these repetitive spiking, but essentially same type of distribution of the areas activated. Another seizure here and another seizure there. Almost it's very stereotypical, which is very comforting here in the analysis of seizures recorded from any invasive recording, in particular in the SEEG. Now, if we're going to map the seizure here, we're going to see V, L, and F, then D and P, then M, Q, R, S. And in this sequence, as we showed earlier, but at the same time, sequence is not only by to be time locked together, it is by the degree of involvement and the progression amongst various type of ictal and interictal pattern to basically show us that this is part of a very well connected network. So now we were able, by stimulating the F electrode, which is the more anterior temporo-occipital, basal temporo-occipital electrode, able to reproduce basically some of these seizures finding, in particular with the evolution of the seizure, taking involvement the M electrode here, as you can see, some of the W electrode in parietal, M frontal eye field, and the frontal opercular region. It's always comforting when we are able to reproduce the seizures, not only the electricity or the clinical manifestation, both the electro and clinical manifestation of seizure related to the same anatomy of a spontaneous seizure that is recorded on the SEEG. Now here, if we put these things together, we can reconstruct the seizure, as I mentioned, V, L, and F, moving up to dorsal to D and P, and then more anterior to the frontal opercular and frontal eye field. This led to the, in this case, the resection involving the basal temporo-occipital region, as you see, with limiting this at the more posterior areas. Now the question here, should we have gone more posterior? The question, we don't have an electrode here, but we relied on semiology. The patient did not have any history of a visual aura at all. So basically we focused on this part of the network that is, as you see, highly connected anterior to the temporal lobe, which were very quiet, but mostly here taking a dorsal to intraparietal sulcus, superior longitudinal fasciculus 1 and SLF3 here involved. Now, the SEG ictal onset patterns, they're not always the same. And that is, I think, a big challenge sometimes, in particular when multiple electrodes are involved at once. And in this situation, the big question comes, what is the onset? What is spread pattern? Now, these are some of the patterns here from our analysis of our SEG cases. We see various patterns, bursts of spikes followed by low voltage fast activity. The burst of spikes would be followed by repetitive spikes, low voltage fast without pre-ictal spiking, and continuous spiking, which we sometimes see more in the patient with type 2B dysplasia with low voltage fast activity. Now, an ideal seizure is a seizure that you can see an onset here. Let's say, for example, is one in the basal anterior temporal region. Next, followed by anterior temporal polar involvement. Then it is in the mesial temporal region, both C1 and B1 electrode. In cases like this, the mapping of the electricity, if it does correspond to the mapping of semiology, and the anatomy makes sense in the context of our hypothesis, that would be more than enough to decide on the ictal onset and to come up, at least make the first step to generating a hypothesis how to, what type of surgery should be done and the extent of the resection. But in some cases, unfortunately, we see something like this, where it's very difficult to find out which electrode or electrodes are seizure onset. Most of them are involved, and then almost half of them we see the seizures progress into. These are the cases where we ask the question, where is the epileptogenic zone? And then in most of these cases, if this is only information we have, we will have to pause and decide, should we implant in additional areas? Was our hypothesis wrong? And or what should we do here? Now, one way here to analyze the EEG, and this is the role of what we call EEG post-processing, come to the mind, and we talked a little bit yesterday on doing post-processing techniques, in particular those based on some AI-based model development. But this is here before AI. This is like time frequency analysis. This is work that was led by Patrick Chauvel. And what Patrick basically talked about here is this pre-ictal spiking. This is the frequency here. This is the time of the seizure. That's why it's called time frequency analysis. In the beginning, you have fast and slow activity together. But at the beginning of seizure, you have a burst of fast activity. And there is like a double band in the gamma range that is basically in the beginning of seizure with almost absence of any slow. And we within 10-15 seconds, this will evolve into a slower activity that is becoming more prominent in the ictal onset, and then most of the time it is spreading to other areas in the brain. So and this is what Patrick called the fingerprint, the SEG fingerprint, which is characterized by three things: pre-ictal spiking, pre-ictal spiking, fast activity, and suppression of the slow. Now, more recently, one of our colleagues here, he developed an AI model using raw SEG data in order to come up with better ways, more objective ways to analyze the SEG and to come up with potential localization of the ictal onset zone. Without going into too much detail from our data here, he found 9 reproducible ictal SEG phenotypes. You can see here, this is time frequency here, to look at not only the time, what I just mentioned, the EEG fingerprint or some part of the EEG fingerprint. There are other models in the time frequency evolution during the seizure that were associated with the ictal onset zone, as evidenced in these patients by post-resection achievement of seizure freedom. Now, here, this model, this seizure onset zone classifier, was shown to be highly performing, basically more than 12 times the baseline AUPRC on an independent set that is used for validating these experiments that is not used for the training or the testing of the set. So, completely independent patient population. And this model performance was independent, was tested on independent unseen data and showed dramatically better results than baseline, and that showed a very significant reliability and generalization. The point here, sometime if we see a pattern like this, we always ask the question, are these two, the electrodes, the ictal onset? Is one of them the ictal onset? If so, which one is it? And these are the biggest questions that we have when we, by design, map networks. We know the frontal lobe in no time is connected to parietal lobe, and they both are involved. And hopefully using models like this, and to some extent the EEG fingerprint time frequency analysis, will get us to differentiate between the ictal onset from the spread, or what here Ballou called the non-involved zone. Now, what about seizure induction, and does it have a value? This is a very nice paper between French and Italian groups, basically showed that low frequency stimulation and high frequency stimulation can induce seizures, and when it does induce seizure, the best outcome happen when the electroclinical manifestation of the spontaneous seizure or characteristic spontaneous seizure is the same as the one by the induction. And probably the seizure onset zone, it is induced by the low frequency stimulation. In our setting, we use both low frequency stimulation and high frequency stimulation. And again, the value of this, if we can 100% reproduce the electroclinical anatomical manifestation of the recorded seizure. Otherwise, the value is questionable. This is here a small example showing a spontaneous seizure, showing a seizure after stimulation, basically giving us more or less activation, or the pattern of activation in the same set of electrodes, with probably a little bit more in the spontaneous seizure, as you see here. To summarize here, what I tried to convey is there are some principles here for SEG interpretation. The most important one of which is the fact that, we have to demonstrate that the region suspected of being involved in the seizure onset and early propagation show what we call the expected ictal pattern. So if we have a hypothesis, it is in basal temporal occipital region, we should be able to show that early change happen in that area, and the organization, an area that is directly connected with, in this situation, it may have been the intraparietal sulcus. And then, again, as I mentioned before, we have always to consider, in particular in cases where we look at the SEG pattern, we see more than one patterns leading to the same activation of same number of electrodes and same locations. Consider the fact that this may have been a propagation of an ictal discharge that was generated elsewhere, and most of the time this is generated in a silent area of the brain. And the group, the Banco and Telerac, they spoke very clearly that when you have a scenario like this one, you should not be shy from add an electrode to the implantation. In our setting, we have maybe around 5, maybe 10% of the cases where we find ourselves adding electrodes because at times we are in this situation where we suspect there was a propagation pattern to the ictal onset that is outside our hypothesis that we need to take account for. Now, the third principle here is obviously like for subdural grid, for the intraoperative ECOG, is we need to define the border of the epileptogenic zone. This is something when we started using SEEG back in 2009, we were very nervous because we are used to have the subdural grid here. And then the subdural grid will give us a two-dimensional analysis of the extent of the abnormality. And here, as I mentioned, part of the hypothesis should be to have electrodes in the four corners of that hypothesis, dorsal, ventral, anterior, and posterior. And at the same time, the anatomy could be a sulcal anatomy, gyral anatomy here, may represent one of these borders. And then, of course, like every time we do epilepsy surgery and discuss the removal of one area, we have to talk about the feasibility of the surgery, if it's feasible or not. For example, an area that always is problematic from surgical standpoint could be the posterior dorsal insula, for example. And then last but not least here, we need to make sure that we have a good reconciliation of the overlap between anatomy and the anatomical area, anatomical lesion, and the epileptogenic zone. And then I will end here by acknowledging my many wonderful colleagues here from whom I learned a lot, and I continue to learn every day through discussions. In particular, I want to mention Juan Bulacio, who's leading our epilepsy SEEG program, and our teacher, Patrick Chauvel, who was, his presence with us was transformational. Thank you again for your time here listening to me.
Thank you very much, Yimat. Beautiful talk as usual. So, someone has some question for Professor Yimat? Everybody's shy, so you will liberate you. So thank you very much. Oh, there's Andrea as usual.
Yeah, let him come here. I like to see Andre.
I wouldn't. That's a shock here, electrical shock. I wouldn't like. First of all, thank you for this very elegant and instructive talk. Could you tell us what was that suggested perhaps left temporal-occipital onset in that particular case you showed? After you had this idea of the network, the initial network involved mostly the ipsilateral intraparietal sulcus, which may usually have ipsilateral non-tonic deviation, and then there was this issue of the perisylvian, etc. So was it by chance? Is it that you always go down? I understood you said that you have to cover around, but let us develop this a little bit for us, please.
Yes, of course. Andre, as always, very insightful comments and questions. Yes, well, I did not show a couple additional things in this case. We have a PET scan that showed bilateral temporal, actually, the anterior temporal hypometabolism, and a MEG showing two clusters of dipoles, one in the temporal occipital junction at the notch between temporal occipital basal, and the other one actually anterior temporal pole. So now, one thing I did not mention, and I'll talk about it tomorrow in the context of analyzing semiology. There is, I had to learn myself, like from beginning when we started to use SEEG, the networks and connectivity in the brain. So we know there is a very strong connectivity to the intraparietal sulcus coming from the posterior perisylvian region, superior temporal gyrus, and the fusiform gyrus at the junction between temporal and occipital lobes. So thinking, okay, we know that intraparietal sulcus is more likely involved, the eye field is more likely involved, the frontal motor area more likely involved. Now, could it be another silent area or silent areas connected? Considering the EEG is in the back and the left, we thought maybe we're going to go a little bit
down.
ventral.
Yes.
And then going all the way to the temporal occipital. Now, if the EEG was not as clear, we would have implanted same areas, but we would have added one in the, or some, another hypothesis in the frontopolar region. You know, frontopolar, because it's another region that can spread directly to the frontal operculum and through the Aslan pathway go into the frontal eye field. But because the EEG and the PET and the MEG pushed us posteriorly, we took a chance or a risk and we did not go anterior. And then if we think about it, every time we put something basal temporal occipital, we put something temporal polar. And this is basically looking at the inferior longitudinal fasciculus, taking the occipito-temporal orbitofrontal fasciculus that we always try to map it for connectivity here. We did not extend it orbitofrontal because of the EEG.
Thank you.
Imad, hi, Chris Bujarski.
Chris,
from
how are you
Dartmouth.
doing?
Hey, good. Nice to see you.
Nice
Thank
seeing
you
you too.
for your lecture. It was, really appreciate it. It was very elegant. I wonder, I have some clarification or question about kind of what you said about following the semiology sort of with the SEEG electrodes. So the idea, as I understood what you said, is sort of figuring out the aura and putting electrodes there, and then as the semiology evolves, kind of laying out your SEEG plan to follow the semiology. Now, I always think of it the other way around, where you start with the aura and think about what pathways can sort of lead to that area, because those are that's where you sort of find these silent areas that you're talking about. So I think of it the other way. So I wonder if you could clarify or sort of maybe talk about that a little bit more.
Absolutely, Chris. This is a wonderful question. Let me explain myself here. This is very good. So we basically take into account both, Chris. The first, when we analyze a seizure, as I mentioned, and this is what when Patrick talked about the order and sequence in the seizure semiology. So it is extremely important, part of their principles that they define for SEEG. If you record a seizure, each element or each part of the seizure should have an electrode where you're recording the EEG from. And this recording should correspond to the same sequence of events of the seizure. If it does not correspond to the same event, it means we missed the onset. It's coming somewhere else to all of these areas. Now, this is number one. Number two, we never forget the second point that you mentioned, which is when we come up with this, we go forward from the first symptom or sign and create a map of the implantation, and then we stop and then go back. Where is the first symptom or sign? And we say, what is it connected to? And then we'll add to this hypothesis. So we take into account both.
Thank you very much.
Of course, thank you.
Some other question? Okay. So thank you very much, Imad. See you tomorrow.
Yes, tomorrow morning. Have fun.
Wait a minute. Eliseo wants.
Oh my God, yes, absolutely, my good friend.
Thank you for your beautiful lecture.
You are in trouble, Imad.
Yeah. Now, I just want to know from you the interictal ECG versus the ictal. If there's any difference looking and if you always need to have seizures, or the interictal activity may help you to decide?
Well, I think this is very good question. If we think about it from the ECOG standpoint, we talk about it from subdural grids. We used to put a lot of weight on the interictal because, as we know, when we talk about ECOG, we're talking about anatomical area. We're not putting big networks together. What we found out, and it was not, we didn't find out, it was described many years before, when you put electrodes in a network, any part of the network involved, you're going to see the spike almost everywhere. So the distribution of the spike is so widespread in most situations, not always. You know, your type 2 dysplasia, which we don't implant anymore, tell you to do, will see it very focal. But the fact that interictal doesn't localize as much as the ictal. And ictal does not localize, in fact, but ictal will give you a progression of the pattern and the organization of the pattern with the progression of the seizure that will, going backward, reconstitute the network involved and potential the ictal onset. But so interictal activity is less of an importance than the ictal activity, but the ictal as a sequence of events rather than one single one.
Okay, thank you, Imad.
Okay. See you tomorrow, Imad. Tomorrow
Okay.
morning.
Bye. Bye,
Bye.
everyone. Have fun.
Bien, vamos a hacer un cambio en el orden para que no se duerman. Y ahora viene la doctora Bárbara Jobst, que nos va a hablar de la rehabilitación, de la neuromodulación en epilepsia, modalidades y resultados.
All right, nice to see you all again today. I'm gonna go a little bit to neuromodulation, which is, I know it's not, that's the next one. Yes, this one. I know it's not available here, but I'm gonna give you some data and just that you can render your own judgment where you wanna go. So yesterday I kind of introduced you to this algorithm here, that the major message I wanna give you here, that if you can resect, you should resect. So no neuromodulation device is as good as you can do with epilepsy surgery or a resective surgery. So I have, again, I'm the person of stories. When I was a young faculty, I said, okay, and then actually the RNS device came along. I said, okay, in the future, we will never take out a temporal lobe again. We'll do much better. We have these devices, and we leave the temporal lobe in, and then we don't have all these memory problems, et cetera, et cetera. I'm very sorry to report to you after 35 years in this field that still the best thing is a temporal lobectomy. So we haven't made much progress, and maybe we should think about that also a little bit. However, I'm gonna give you a little bit of a whirlwind tour what we could do with neuromodulation. So if you can't resect, then you should really think about these other things that are the VNS, the RNS, or the DBS. So the vagal nerve stimulator, you know, it's a generator in the chest. It's like a pacemaker. It goes to the vagal nerve, usually the left vagal nerve in your neck. It has been around for a long, long time. Then there is the DBS. The DBS was initially invented or used in Parkinson's disease. It does great things in Parkinson's disease, and sometimes I feel like we could talk to each other a little bit with the Parkinson's people and movement disorders people. It took a long time that the DBS got approved for seizures. That already also tells you a story, because if it were to cure epilepsy, it wouldn't have taken as long. And then there is also the RNS, of which I'm a big fan, actually. I'm not saying it's the most effective thing, but I will also show you we learned a lot from the device that we did not know before. So I'm talking about the VNS. So how good is it really? And the VNS has been around since the 90s, and actually I like to say it's a medication without being a medication. And one thing I want to point out here, that we are talking about seizure reduction. Everything we talked about this morning was the percentage of being seizure-free with epilepsy surgery. Now we are talking about a 50% seizure reduction. And I go back to, instead of 4 seizures a month, you have 2 seizures a month. Not gonna make so much of a difference. And if we look retrospectively, you may reduce seizures by like 64%. And if you, it depends what population you look at, it's always between like 50 and 64%. However, if you really look back on the first randomized controlled trial that was actually done in the 90s, the VNS did really terrible. It only reduced the seizures by 27%, and only 1% was seizure-free. If you now look back, maybe 8% are seizure-free with VNS, which comes back to the medications we discussed before. 8% of patients, if you fiddle around with medications, also become seizure-free. So, but where is the place for VNS? And often it's actually used in the more catastrophic epilepsies of what we talked about this morning. And there often the question comes around, should you rather do a VNS? After we, of course, have excluded that we can do any type of surgery and resection, what we saw this morning, whether we should do a VNS or we should do a callosotomy. So here's a big kind of meta-analysis where you see what the VNS in this meta-analysis was used for partial, back then it was called partial seizures, generalized seizure, and other seizures. And again, the percentage of patients being really seizure-free is somewhat low with 4.8%. If you look at the same population for callosotomy, there are the amount of seizure freedom is certainly higher, especially drop attacks, and there it comes again to the individualized treatment, that what is the worst for the patient and the family. Drop attacks are usually associated with a lot of falling. It's often not realistic that those patients become seizure-free. And so your rate of seizure freedom with a callosotomy, it's much higher than with a VNS. And here you see some predictors of what does predict whether you have a good response to a callosotomy or not. So then the question comes, what should you do first? Now you have a severely developmental delayed patient. Should you first do the callosotomy, or should you first do the VNS? And actually that question is totally unanswered. So whatever you feel like is the right thing to do, again, it's really the seizure reduction is much higher with a callosotomy as it is with a VNS. However, there are also complications. So you may have disconnection syndromes that can be quite significant. You can have some akinesia and all these other symptoms listed here with a callosotomy. And of course, with a VNS, it's not without side effects either. So also, again, a story out of my life. I go to an event of our Epilepsy Foundation with patients, and there's one of my patients who feels very honored to go and walk at this epilepsy walk with me. So I walk with her, and she has a VNS. And every 3 minutes, her voice just gets very hoarse. And if you have a conversation with somebody where the voice gets very hoarse every 3 minutes, it's actually kind of annoying. And I'm sure the patient doesn't appreciate this either. So these are also things you need to kind of consider. Of course, you can always adjust the amplitude, etc., but it's not, the VNS is not without side effects. Of course, you can also do both, and this is what Jenny, I just put it out because Jenny wrote this, and you know, if you do both together, this also can be quite effective. Now we come to the intracranial stimulators. So if you don't consider VNS, maybe you want to do an intracranial stimulator. And there you can either do the DBS or an RNS. And this is an unresolved question, at least where we are right now. Which one is the right stimulator? Should you go for DBS, RNS, VNS? Which one? It's really always a question where there is no yes or no answer. So I want to talk to you a little bit about the RNS, the responsive neurostimulator. Here you see the device. It's implanted into the skull. It has 2 electrodes. Each electrode has 4 contacts. You can either use a depth electrode or a strip electrode, whatever you want. You can put it into both hemispheres of the brain, so it's very good for patients like this who have bitemporal lobe epilepsy, because you can put an electrode in both hippocampi. As you see with one of our patients here, and here you see the device. Actually, most of the device is actually battery. There's only a little kind of chips in here, and this is all battery. It is not rechargeable at this point. It needs to be in the skull because it actually records electrocorticography about 3 minutes a day. You can choose and program it, what it records. So here you see like a typical ECOG recorded with an RNS. There's a spectrogram. Here you see the seizures. And this is one of our patients who had those seizures here. And the patient actually gets a laptop with what's called a wand, that the wand interrogates the device, and the patient is supposed to every day download the data and send it over the internet basically for the physician to review. So you need a patient who is willing to do this every day, and it's actually quite a burden, and it definitely correlates with how well they do. If they do very well, they quit downloading, and I can plead and I can beg and please download. They will not download on a daily basis. Also, I've had patients who said, oh, I feel like I'm a robot and I'm whatever controlled by outside. So these are all things you have to kind of really, this again comes to the kind of personalize what you do in your approach. And here is how we thought it would work. So this was actually a patient had seizure onset in the mesial frontal region, has a nice seizure here before stimulation. Then we stimulate. We thought then it would stop, whatever happens, and the patient would basically not have a seizure, or the seizure would be aborted, and this is what we thought would happen initially. Turns out reality is always different than you think. How it actually works, it treats many times a day like these bursts that look like the onset of a seizure. You never know whether this would have become a seizure or would not have become a seizure. And however, this probably modulates the underlying cortex tissue, that the likelihood to have seizures becomes much lower. So it actually treats the surrogate. It's not really, sometimes it does, but it's not the most common thing that it really aborts the seizure as it does here. This is the first randomized controlled trial that was done. And actually what we noticed there was really interesting. So the trial was done, we put the device in all patients, and after we let them heal for 2 months, actually, which was just out randomly, we choose this amount of time. And then we noted, and then one group we switched on, which is this group here, and now the blue group is the one that switched on. The dotted group is the group that was not switched on. without the patient knowing. So during the trial, we had to pretend whatever, that the patient doesn't know whether they're on and off. It was very complicated. And however, what we noted, if you stick the stimulator in without doing anything, not switching it on, nothing doing anything, your seizures drop by like 20%. And now we know it's called the implantation effect. And what's basically, if you stick anything in the brain, anywhere, you get 20% less seizures for whatever reason. And so this is called the implantation effect. And then you see nicely that the blue group, like the seizure frequency decreases, while actually the dotted group goes up to the baseline seizure frequency after about 5 months. And that difference is actually statistically significant. And then you see here, after we switch those on, actually they have quite a significant reduction in seizures. So the device is effective. This is the mean differences in seizure frequency that led to the approval of the device. And now we have actually long-term data. And it's about the same whether you put the device in for neocortical epilepsy or medial temporal lobe epilepsy. This is a mean seizure reduction. Again, not percent seizure free. This is a mean seizure reduction. Initially, the percent seizure free was about 15 to 17%. Now we have 9-year follow-up, which is about 18%. Then there was a study of real life after the device was approved. And these are very reliable numbers that you have a 74% seizure reduction and 18% are seizure free. So it's 18% versus your 64 to 85% of your temporal lobectomy. So it's still not as good as a temporal lobectomy, but if you can't do resection, it's definitely a next step forward to what you can do, or in patients with bitemporal lobe epilepsy. And there's actually a study, the study which I mentioned yesterday is submitted, and there the percent seizure freedom is, it's like 22%. It's not out yet, so I can't put it up. So, so what did we learn? So now we have these ECOG that we can see all the time. So we see those ECOGs on the patient, living patients walking around, what they do. One thing I can tell you, that what patients report and what we see on ECOG has no correlation. So patients say they have a seizure, sometimes you see it, sometimes you don't see it, then you see all those things and they say, I'm fine, I didn't have anything. So seizure diaries are a very poor way to collect objective information. And then what else we learned, this is also really interesting. So you see often these things that look like seizures, but the patient is totally fine. So they're probably subclinical, or they don't report it, or they forget it, or whatever. So the correlation is really not one-to-one. And then if you go to patients with bitemporal lobe epilepsy, the really interesting thing is there that the average time, so you implant the patients with a bilateral RNS, and it takes about 40 days until you see a seizure on the other side. So that means if we do our ECOG, our SEEG with 10 days in the epilepsy monitoring unit, we may totally miss the other seizure because it never happened. So this is one lesson we really learned, that probably more temporal lobe epilepsy is bilateral than we think. And then also, there were patients where from the scalp, the epileptologist was convinced they have bilateral temporal lobe epilepsy, most of them was probably without an implant, and then they only had unilateral intracranial seizures. So be aware that what's happening in the brain and outside the brain may not always correlate. And then I want to talk about this patient, which actually what then this brings up if you have therapies like that. He was one of the first patients in the trial that we did. He was 26 years old, had mesial temporal sclerosis. However, on the WADA, he had no memory on the contralateral side. So we were very leery to resect his hippocampus. So we implanted an RNS in 2006. And he eventually becomes seizure-free with the RNS. He is driving and living a happy life, has a wife and goes hunting and whatever he does. But still, I see those things. So he comes in, says, I'm totally seizure-free, but there are those that looks like a seizure, if you ask me. This is an intracranial seizure. And I ask his wife, I ask his mother, like, does he have a seizure? Do you notice any? No, he has no seizure. He's totally fine, no seizures. So the question is, do I let him drive? So now, because if I would not have this information, I would let him drive. Patient walks into your office and says, I haven't had a seizure for 5 years. You say, sure, go drive, no problem. So I was kind of pondering, should I or should I not let him drive? I finally decided, okay, let him drive. We are in New Hampshire, he needs to drive, happy life, whatever. So then he comes back one visit and I see this. So this is a little bit of a bigger thing. This was in September 2020. And I was like, I'm not sure. I need to go back here. I was not sure what this is, but he comes in, says, I'm fine, I didn't have a seizure. Wife says, I'm fine, didn't have a seizure, whatever. So, okay, I could take it. However, on the 4th of January 2021, this happens. He drives. He obviously has a seizure. Of course, also human things play into this. He's not seat belted. His wife is seat belted in the car. He gets ejected from the car, and then you see after the seizure it goes flatline, and he dies. He dies in this accident. And I have to say, for myself, this was hard to take. So also we always have to think as physicians, we are also humans. This was really hard to take. I let him drive. Did I kill him, basically? And actually we wanted to get the device. We had to, with a whole other story, get the device out of him. And so so I was wrecking my brain out, and I just want to end the story how human it is. So finally, after a day or two, I have the courage, and I call up his mother and say, I'm so sorry that this happened. I probably shouldn't have let him drive. This was probably a judgment problem on my side. And my mother said, yes, it's sad that he died, but you gave him a normal life for 15 years. And I still don't know whether I kind of made the right decision at this point or not, but it's something to really think about, and also something to really think about what decisions we make have for the patient. So this was kind of the touchy-feely story for the day. I will go on about science further, but so this is then the things we are faced with if you have technology like this. What else did we learn? So I told you already, the seizure diaries are not concordant. It's not clear what all the things like he had, what it really correlates to clinical seizures. And what I have to say, what I feel like I know less and less, the longer I do this, I know less and less what a seizure is. When I graduated from medical school, I knew exactly what a seizure is. Now I have no idea anymore. It's somewhat a continuum between something that happens somewhere, and it's really a continuum. It's not an on-off switch. And also, how do we deal if we have stimulators like this? How do we deal with the legal consequences? And then the other thing is, like, epilepsy seems to always go ahead. You try so hard to eliminate it, and it always wins. So it's ever changing. So it's also something to just keep in mind. Taking this a level further, So the RNS is actually approved for focal epilepsy. Can we take this to generalized epilepsy? So or the DEEs, really the severe epileptic encephalopathies. And actually we have tried in a few patients to actually put the RNS into the CM nucleus of the thalamus. And that's actually an interesting patient because, so these are recordings now in the thalamus of this patient. The patient has severe DEE. He does actually quite well. He was on many medications, quite sedated. With the RNS, he did quite well and is now only on 1 anti-seizure medications, which made his development, coming to your point, really progress. And he also had a previous callosotomy. So you see that the seizure in the thalamus either is on the left or it's on the right. So that's actually, and these are thalamic recordings of this patient. There was a study called the Nautilus study for idiopathic generalized epilepsy with the RNS, also in the CM nucleus. Unfortunately, the study was not very well designed, and it did not reach its primary endpoint, which was the time to first seizure. So it doesn't mean it's not effective. We had 2 patients in the Nautilus study, did very well. However, we will see where this will play out in the future. Coming to DBS, so now I told you all about RNS. The good thing is about DBS, you don't see those things. So you don't record ECOG, you don't see it. The things with Kevin probably wouldn't have happened or wouldn't have seen it. And what do you do with DBS? You put it in the anterior nucleus of the thalamus. You modulate the limbic system. And what's really also striking, this is the initial study for TBS. And what you see here, again, this time you stick the electrodes into the anterior thalamus, and you again just reduce the seizures by 20%. So whether the stimulator is off or on, no difference. And actually the results between NeuroPace and this trial are fairly similar in terms of differences between on and off. This stimulator is what I call usually a fairly stupid stimulator. It just goes off every 5 minutes. So it's 1 minute on, 5 minutes off, and you stimulate at a certain amplitude and frequency, but the results are very similar to the RNS. And also the long-term outcomes are very similar. So if you go out years, 5 years after, you have again about whatever 50 to 70% seizure reduction. However, what gave me a little bit of a pause is this study here. So this was a registry it's called the MORE study. And this registry was in Europe. Everybody, they put in a stimulator in the ANT for epilepsy. And actually the results are kind of dismal. They only had a 32% seizure reduction at 2 years and a 53% seizure reduction at 5 years. So now they're of course looking why it is and were they not placed in the right place. So this is still, the word is still out. Which stimulator we should implant. And often we in our epilepsy conference, we don't know. Should we put in an RNS or a DBS, or who is the ideal patient for this? Who is the ideal patient for that? We do both. And probably it's more the flavor of the day than really rational decisions. So we have to learn much more about that. And the last thing, there's actually a video. Maybe you can make the video work. Let me see whether. Hello, there's a video. Can you? Oh yeah, okay. So, don't start it yet. Don't start it yet. Can you stop it? No. Oh, now you see. So you see left a rat and right a rat, and the left rat has a seizure. And the right rat gets stimulation, actually of the CL nucleus of the thalamus. and also has a seizure actually in the hippocampus, but goes about her normal way and does not lose consciousness. So how do I come to this? So actually Hal Blumenfeld, who you see here, comes to me and says, "Hey Barbara, I want to do this study where we stimulate the CL nucleus of the thalamus to keep people more conscious during seizures." And I'm like, I don't think so. I think this is all total nonsense. I didn't even know where the CL nucleus was, by the way. And but then he showed me this video, and I see those rats, and then maybe he has a point. So we write a grant. It gets funded for some miraculous reason, and it actually set us off on this START trial. So where we actually have a stimulator that works like the RNS I showed you. So we would stimulate like the RNS in the hippocampus, and then if the RNS is not stopping the seizure, we would go to the thalamus and stimulate the thalamus to keep the patient awake during the seizure so that they at least would not lose consciousness. So, and this is a stimulator that was made specifically from Medtronic for research. It has 4 electrodes, not 2 like the RNS or DPS. It has 4 electrodes. 2 would go into the hippocampus, and 2 would go, so these are the hippocampal electrodes. So we would stimulate first in the hippocampus and see if the seizure persists. And if it persists, then we stimulate the CL nucleus of the thalamus. And here you see the implant locations, and here you actually see, so if the seizure was stopped, we would just do hippocampal stimulation. If it didn't stop after 5 minutes, then we would trigger the CL stimulus. And our primary outcome was not seizure frequency or how many seizures you had. Our primary outcome was whether you would lose consciousness or not during a seizure. How did we measure this? So here comes the real high-tech stuff. So how do we test consciousness? So here you see all the devices that were involved into the study. So you get that Medtronic stimulator with these 4 electrodes that talks to this communicator. Let me see, so you have your stimulator that talks to the communicator, which is this thing here. Then this talks to a tablet, which is here. The tablet talks to an iPhone, and the iPhone talks to the Apple Watch. So this is how this goes here. And then if the stimulator would recognize a seizure, and CL stimulation recognizes a seizure, then the Apple Watch would go off and ask you questions. And you had to answer to the Apple Watch. So you just have to think about it. Something goes off in your brain with ECOG. It triggers an Apple Watch. The Apple Watch asks you questions about your name and what date it is. And this is how we assessed consciousness. And you can, of course, imagine this is a technological nightmare. And also the patients have to charge all these devices. So they have to charge the iPad and the phone and the watch, and it's kind of but somehow we pulled it off. And how did we do? So this first was a feasibility study where we enrolled 5 patients. We first, also in the study, admitted the patients, let them sleep, and then during sleep, triggered CL stimulation and see whether we could wake them up. And yes, we could. So just with stimulating the CL, it has to do something with arousal, and we could wake those patients up reliably in sleep. Our outcome is consciousness, measured by this, what we call the RD watch. And what we did, we had seizures where we applied CL stimulation, and we had seizures where we did not apply CL stimulations. And we had scores of consciousness through the Apple Watch. And of the 5, 3 had improved consciousness during the seizures. 2, we could not really say because 1 never had a seizure with loss of consciousness again after we put in the hippocampal electrodes. And the other also probably never really lost consciousness during her seizures. So this is like the data in kind of a nerdy way to show it. And this is where we are with START. I don't know where this is going. It's hard. We don't have a stimulator with 4 leads. But this is where we are going right now with neuromodulation, and I am very happy to answer any questions. Thank you. Yeah.
Thank you, Patricia. Did you mention that after so many seconds, if the patient didn't regain consciousness, then that simulation would go off?
Now, not consciousness. If the seizure was 5 seconds electrographically in the hippocampus and didn't stop, then
5 seconds.
5 seconds. And it was
Okay.
a total random call.
Okay,
I remember we were sitting in a meeting and Hal was asking me what is an appropriate time to trigger CL stimulation, and I had no idea, and
So
I just
5
said
seconds.
5 seconds.
Good. So good. 5 is a good number, right? Between 0 and 10. But let me ask you something. What do you mean? Then you launch the simulation, you trigger.
Yeah.
Who is the you? You see, I mean, the patient is walking around.
The
okay?
patient is walking around, so the patient needs to have the iPhone with it and the iPad close. So you need to have the iPad in the house and the iPhone with you. And then automatically,
Oh, after 5 seconds, automatically the other triggers. Is that it? I mean,
right, so any seizure will trigger the RD watch. So if the device sees a seizure intracranially,
okay.
then the watch will go off and ask you questions. The watch will also go off sometimes during the day to make sure.
So you're there and it's charged. Okay.
Right.
But one thing it's important is who and what triggers the second stimulation or the CL stimulation?
It triggers if it detects for 5 seconds, automatically triggers the CL stimulation. As I say, this was at the most, and I have to give, so it was not only Hal Blumenfeld, it was also Mayo Clinic, and actually they did the, with Greg Morrell, and they did all the engineering. So we had an engineer who really kind of built this thing that after 5 seconds it would trigger that CL stimulation. And it really is tricky to get those stimulators to do what you want them to do, which is, this was a research device, and actually this is also where we are now stuck. We would like to take this further, but Medtronic is not interested in continuing to produce the device. And where can we get a device that does this, what we wanted to do? Because this is another discussion. The markets are too small for those to.
You use what you see, you take what you see, and then you try to give sense, biological sense to this.
Yeah.
In terms of what happens in a seizure that are now called focal seizures, altered consciousness, that used to be called
Focal unaware seizures.
Focal unaware seizures, and used to be called complex partial seizures. So what happens in the brain, in your view, from what you've learned, that makes people switch from feeling an aura, okay, and then they go blank? What is that?
So there's actually a paper you should look at that also came out of the study. So we did actually look at just seizures and the loss of consciousness during seizures. So we always think that for example, you lose consciousness less with right temporal seizures than with left temporal seizures, which is probably not true. It's probably, I think, the loss of consciousness, and this is actually Hull's theory, comes from that the thalamus controls basically the neocortex. And if you take this control away, then you lose, that is the losing consciousness. We have endless discussions about, is losing awareness the same as losing consciousness?
Yeah. You see,
And this discussion, like we had this discussion endlessly at like an ILAE meeting, and I personally believe that awareness is something different than consciousness, but consciousness is not one thing.
Right.
There are many, it's like a seizure. It's not like an on and off, you're conscious or unconscious. There are many variations of, it's a gradual thing. With consciousness is probably the same thing like with seizures. It's not an on and off switch, it's biologic.
Are you aware of this old paper from Professor Pierre Glor
Yes.
on
Yes,
supplemental
yes,
epilepsy,
yes,
right?
and I have actually, have read all this papers from Peter Glor in the past, and actually my fellowship project with Peter Williamson was finding out the role of the thalamus in generalized tonic-clonic seizures of focal origin. Of course, back then we did not have any thalamic electrodes. Now we do. It's actually kind of funny how life always comes back. And maybe it may be worthwhile looking again, like repeating my fellowship project to see what is really and I think the thalamus is, and this is where the thalamic therapies are really a good idea in terms of stimulation therapies, because it's a really, really important relay station, as Peter Glor already recognized in the 50s with the centrocephalic theory. I know all about this. But also we have to say the people in the 50s were pretty smart too. So they weren't like, didn't know what they were doing. And it actually goes along the same avenue like that work.
¿Alguna otra pregunta?
Hi, thank you for your talk. That was very interesting. I'm a functional neurosurgeon and I do DBS for Parkinson's, so I'm kind of a big fan of it. But I was wondering, you know how local field potentials and adaptive neurostimulation has somehow improved results in Parkinson's.
Right.
So I was wondering if there is any research in epilepsy with adaptive neurostimulation.
So what's currently happening, because the DBS devices are getting somewhat smarter, to actually also try to use something like adaptive neurostimulation that they use in Parkinson's disease for epilepsy. However, the problem with epilepsy is it is a intermittent disease. So you have a Parkinson's patient who comes in and they shake all the time. So there you can make a judgment during the clinic visit what to do. If the patient shows up and has no seizure, nothing I can do. Like, it cannot, and I know they try to get around it with these, the Percept and stuff can now record these events, and we record the events, and then, you know, they show me the power spectrum, and then I'm not really sure what it means. I think seizures are a little more complicated, but where I totally agree, the field of Parkinson's disease and we in epilepsy, we have gone in two different directions regarding brain stimulation. And we could learn from what the Parkinson's disease people learned in terms of motor action. And probably we could inform you a lot too in terms what you can sense within the brain. We are, after all, the ECOG specialists. So I think there is a lot to learn about that. And in the end, what it comes down to is like what devices are available to us. Like what can you really do with a device that you can, and this is also why I'm usually the RNS fan, because I see what I'm doing. So I see it much better than I do on the Percept. And, but the word is out there, yeah, to see, yeah.
Barbara, you talk about seizure control, seizure reduction, seizure-free, but you don't talk about that they, at least for vagal nerve stimulation, talk about cognition, about depression. What do you say about this kind of results?
So the VNS is also approved for the treatment of depression. It's just not paid for in the US for the treatment of depression. I don't think it has it hasn't cured depression either. It's not as effective at ECT or something like that. In terms of these other devices, it always becomes very difficult to kind of figure out how is the effect of improving depression independent from seizure frequency. And I mean this in a biological sense. It's not that the patients are depressed because they have seizures, but epilepsy and the depression are an expression of their disease. So and we have all seen that, if they have more seizures, they are more depressed, there's post-ictal depression. We have all seen that. And it's very hard to really say, oh, it helps the depression because it probably also helps the seizure. And the same is with neuropsychological improvement. There's actually some of the neuropace, there is reported, it improves, I think it improves language function. Of course, if you have less seizures out of your left-sided language area seizures, you're probably gonna have better language function. So it's always hard to kind of divorce these effects, but they go together. Yeah. Yeah. Oh, here comes the hardest question.
No, but Barbara, yeah, so that's, we keep seeing that the patient report of seizures and their actual seizures detected on the RNS is just not the same thing at all.
It's
completely
not the
different.
same thing at all, yeah.
And, this is such an opportunity we talked about this, I think, in the past, to study medication effects, right, in this development of new medications.
Right.
And because all drugs right now are approved based on seizures that the patient has reported, and if that's completely wrong, then, then why have we been slow to use these RNS patients? And we have thousands of them now to do
want to
this.
hear my honest opinion?
It seems like a very, very easy thing, the FDA should really go after this, it seems like.
So I can now give a politically correct and a politically incorrect opinion. What? Incorrect. I think the pharma companies don't want to see it because it may not show what they want to show, and many drugs have just, it's kind of a regression to the mean why they help. If you really go to hardcore neurophysiology, you may not see the effect you want to see. And I think that's why they are not going down this route. There's one drug company, we didn't get into the trial, who looks at long episodes. So they had a new medication and they looked, so long episodes are seizure surrogates, so there you can actually program in what you detect, and they're usually longer than 5 or 10 seconds of seizure activity, and they are a pretty good measure of electrographic seizure activity. Yeah. Then we would need to have a reasonable government. Anyway, so this was my last sentence too.
Me preguntaba si tal vez tenés.
Oh,
opción?
no.
No. I can do the question later. No, me preguntaba si tal vez en esos pacientes que tienen el RNS y tienen esos registros con crisis y que ni los pacientes ni la familia refieren algún trastorno, si ustedes tuvieron la oportunidad de estar frente al paciente cuando tenía esos episodios o tal vez controlarlos en, no sé, un video G, me pregunto, para ver si realmente no tienen manifestaciones, porque nos ha pasado muchas veces de ingresar pacientes a video G y ver que están subestimadas las crisis.
So of course that could always be the case. That they're very subtle clinical manifestations. So for example, sometimes you have patients and then if they have this indirectal activity and you let them, for example, read, there's a short pause. And so always it could be that we do not detect this subtle clinical activity. And I also believe, but I think we should look at this more like where in the brain the seizure really is. And let's say your hippocampus is kind of knocked out for 30 seconds. Are you really noticing as a human? Because for 30 seconds, maybe you're not integrating your memories. This is like having a glass of red wine. So will you really notice those things when you have them? And I believe that hippocampal seizures can be totally asymptomatic unless you really would go during this time and test their memory to do that. And also with those patients, in some patients, like it correlates well with what we see. Like some patients, they bring in a seizure diary and it's fairly okay what we see on the RNS. And then there are some patients where it really has nothing in common with each other. And I don't know what makes it or breaks it. Is it the reporting? Is it's just a general observation, yeah.
Bueno, muchísimas gracias, Bárbara, una excelente presentación que ha motivado además mucha discusión. Los invitamos a pasar a un breve café y seguimos con la presentación de electrocorticografía y el